Hi, it's my pleasure to present on oncologic applications of MR-guided focused ultrasound. I'm Mark Hurwitz, MD, Director of Thermal Oncology, Professor and Vice Chair in the Department of Radiation Oncology at Thomas Jefferson University and Hospital. Well, there are many emerging applications of MR-guided focused ultrasound. Do you want me to talk about MR, but should I use focused ultrasound, or do you want me to use MR? Focused ultrasound. Mm-hmm. Okay. I'm going to start over. I'm just tired at this point. It's my pleasure to present on oncologic applications of focused ultrasound today. My name is Mark Hurwitz. I am the Director of Thermal Oncology, Professor and Vice Chair in the Department of Radiation Oncology at Thomas Jefferson University and Hospital. Well, we have been discussing a range of potential applications and emerging applications for focused ultrasound. In the realm of oncology, I'm pleased that we can report on the findings of a pivotal phase 3 trial exploring the role of focused ultrasound in bone metastasis. This work was recently published earlier this year. It was a multinational phase 3 trial in which patients were randomized 3-to-1 to MR-guided focused ultrasound treatment versus placebo treatment, in which the patient was set up for treatment, but the energy was not applied. For patients who were randomized to the placebo arm, accounting for this population with bone pain, they were allowed to be unblinded at 2 weeks if they did not have a response and offered salvage therapy. Ultimately, about 90% of patients in both groups believed they had the actual treatment, indicating the effectiveness of the blinding process. The results of this trial were quite striking, in that approximately 65% of patients randomized to MR-guided focused ultrasound responded to treatment, as opposed to 20% of the placebo patients by 3 months. What's important to note is that many of these patients were previously heavily treated, including with narcotics. About half of patients had had prior radiation therapy, so for many patients this was a salvage therapy. Also, prior to formal enrollment on the trial, we had to document that their other treatments had been optimized. For instance, narcotic medications had to be tweaked to the point where there was no further advantage of increasing their regimen or changing their regimen. So for these patients, it truly was a situation where their options otherwise were quite limited. Nevertheless, they had a significant response. Also, in addition to the response itself, the degree of response was notable in that the typical numeric rating scale pain score, which is a validated instrument used to assess pain, decreased from approximately 7 to 3.4 over the 3-month period. And as can be seen from the graph, this was a durable response. It's nice to talk about numbers and p-values, but what's that mean to a patient? In the case of the NRS, a 2-point decrease has been anchored to a typical response of a patient's pain being much improved, and a 4-point decrease, which is what we approximated on the study, has been anchored to a response of very much improved. So this was not just a statistically significant finding, but a very clinically meaningful one. And also, these patients had a dramatic improvement in their functionality as well. Even within 1 day of treatment, that improvement in function was highly significant and continued to improve over a month and was again durable over 3 months. Subsequently, others have published additional results, including Dr. Napoli, who will speak later in this session, as well as the group from Utrecht in the Netherlands, which recently reported on their experience with very similar findings to ours. There are other applications, including breast cancer, for which promising results have been seen. There is a fairly extensive experience in Japan. Dr. Furusawa is reporting at the current meeting the experience using MR-guided focused ultrasound in treatment of small breast cancers. What is interesting here is that they have used focused ultrasound to replace surgical treatment, followed by standard radiation therapy. These patients had biopsy-proven disease and proceeded with the focused ultrasound treatment. In this case, 72 breast lesions were treated sequentially with focused ultrasound, again followed by standard radiation. Tumor size was limited to 1.5 centimeters. There was good median follow-up out to 68 months. They've had no severe adverse events or distant recurrences, and with this significant follow-up, noted 1 local invasive recurrence amongst the 72 treated lesions. And this clearly warrants further investigation. There's also interesting work that has been done in pancreatic cancer. Pancreatic cancer is a devastating illness, even for the 20% or so of patients who can proceed to definitive resection. Most of those patients still unfortunately fail over time, and the majority who cannot even get to the point of surgery are faced with limited treatment options. In a study reported by Dr. Vidal-Jove and colleagues from Spain, they looked at the impact of ultrasound-guided high-intensity focused ultrasound for treatment of unresectable stage 3 and metastatic pancreatic cancer. They looked at a total of 43 unresectable tumors treated between 2010 and 2014. About 2/3 had unresectable stage 3 disease, the remainder metastatic disease. The local response, as assessed by PET-CT at 8 weeks, was 83% with a 25% complete response rate. They noted very encouraging median survival of 16 months, comparing this with historic controls of 6 to 10 months. They also noted low toxicity and treatment was generally well tolerated. Based on these promising findings, further work will be warranted to assess the role of ultrasound-guided focused ultrasound, as well as potentially MR-guided focused ultrasound for pancreatic cancer. There's also been work done in prostate cancer, both with ultrasound-guided and MRI-guided techniques. At the meeting today, we are hearing of a technique using transurethral ultrasound. This movie demonstrates the technique where serial images are obtained, and as you see, the ablation is performed in a circumferential manner with urethral cooling to prevent damage to this important structure. They've completed a phase 1 study which enrolled patients in Canada, the USA, and Germany. 30 patients enrolled with a low toxicity profile as well as a good safety profile. PSA was reduced by 90% with an average nadir of 0.6. Based on this preliminary, albeit promising data, further trials, including phase 2 and potentially phase 3 clinical trials, are being explored with this technology. There's also provocative work being done in regards to how a focused ultrasound can be used to stimulate the immune system. This is a very hot topic, noting there was a plenary session at the recent ASTRO meeting on preclinical work demonstrating the immunologic effects of radiation. Heat clearly has similar effects as documented by many investigators. In a study from Albert Einstein, a novel approach to use of ultrasound using low-energy focused ultrasound followed by high-intensity focused ultrasound to generate an immune response was performed. The group utilized low-intensity focused ultrasound, again in combination with HIFU, and as you see from this graph, there was tumor growth retardation with the combined approach, not seen with either alone or in controls. They also demonstrated that there is an increase in tumor-specific cytotoxic T cells with this combination of low-Fu and high-Fu. These type of T cells can be thought of as the active anti-tumor agents honing in on the specific tumor and helping to destroy it immunologically. One of the greatest potentials, in my view, with the use of focused ultrasound is how we combine this technology with other modalities in treatment of cancer. Cancer therapy is more often than not multidisciplinary in nature, whether it's a combination of radiation, chemotherapy, surgery, and there's no reason to think that the greatest applications of heat will be an incorporation in many instances with these other therapies. For instance, with radiation therapy, cells that are most resistant to radiation, such as those that are nutritionally deprived, low oxygen levels, not actively cycling, those hardest to kill are precisely the kind of cells that are most sensitive to heat. You can also increase blood flow and therefore help enhance the effects of future radiation fractions. Chemotherapy can be enhanced in a number of different ways depending on the drug, including potential synergistic effects. And heat can also be used to help target drug to the desired location within or adjacent to a tumor while minimizing systemic toxicities. And of course, as discussed, there's opportunity to enhance the immune system, including tumor specificity. Noting that approximately 24 prospective randomized studies have demonstrated benefit, including in many instances survival benefit with low temperature elevation, as is done with hyperthermia. The exploration of the potential of the total temperature profile from moderate to high temperature heating is something that will be of significant interest moving forward in this field. Thank you for your attention.